Hello, today I would like to talk about syncope in young patients. This is quite a hot topic if you think about it, because we usually face those elderly old patients. They think in the clinic, or you think about heart disease, stroke, or other stuff. But if that's a young patient, there's a lot you have to think about. Usually, I like to start with a case, so I'd like to present this 35 years old female. She's suddenly faint at home, and like other youngsters, she delayed the visit to hospital till her family member rushed her to the clinic where we are now here, and her vitals are stable. Seems really hard, right? So at this moment, you have to think about the different differential diagnosis, the DDX. Usually you should think about the big boys, the cardiovascular, because those are the one critical, and if you don't treat them immediately, you probably just gonna, they're just gonna die. So you gotta think of the most important one. You have to exclude it, which is the PE, the pulmonary embolism. But this is relatively easy if you know how to exclude it. And the second one you have to think of is arrhythmia. This is relatively more common in youngsters because, especially in these days, they stay night late till the midnight, or they're in stressful life, stressful about their job, their study, their future, relationship, blah blah blah. And then you should think about supraventricular tachycardia or AFib. So, and the next one, even though you think it might not be common in young patients, still you have to think about cardiomyopathy and critical aortic stenosis. This one you have to be aware of this one, because you might think this is a degenerative disease happen when patients or elderly patient older than 65 years old. But if the patient they have congenital valve problems such as bicuspid aortic valve, they are more potentially high risk to this problem. And then the next field you have to think about the neurology part, which is the vasovagal syncope. This is the hard one, and the others, these days they might take something illegal, like cocaine or marijuana or other stuff, and then you cannot miss the electric light imbalance, which you're gonna know after you order the test. And then trauma, you have to observe if that patient have some specific trauma, at the neck. You can just look at it. If there's anything you find is suspicious, just apply the C-collar to him or her in the clinic. Probably those medic already did it for you if there's anything obvious, but not in this case. Still, you have to think about it. Then, after we have some mind in our head, we have to take the history from the patient. So usually you do the ordinary, how the textbook told you, but it's in the clinic. There's a lot of patients yelling, screaming, crying outside, and you don't have enough time to do those 1, 2, 3, 4, 5, 6 steps. You have to ask a little more specific. So, but we start with the usual thing. You ask her, our patient, when does it happen? And I have the answer prepared for you here. And she replied, where she was having lunch at home. And then we heard lunch and then food. And then we just asked, any allergic? No. And then we just continue to ask her, do you remember how long did you faint and what happened? Nope, nothing from this patient. Because if she hit her head badly, then you can also use this information to decide if there's any contusion or epidermal hematoma, or it might be useful for you to diagnose this kind of stuff, but not in this case. And we continue to ask her, did you sense anything unusual before the thing? We can't be too specific. It's so that's how we started. And no, she didn't. feel anything. And then we jump to be a more specific part as what we concern the cardiovascular disease. So we ask her, do you have any chest pain or difficulty to breathe? And then she's like, no, I'm completely fine. And any headaches? No. So we can exclude those big stuff like, sometimes there might be stroke or seizures or other horrible stuff in the neurology department. Then we continue to ask, have you been sick before the incident? Because you might be catching a high fever, some kind of infection or other stuff. Still no. And then we continue to ask her, does she take any medication or any underlying disease? And our patient here, she got depression and she's having her pills currently. And then we asked her, did she take? Is she using any illegal drugs? And then luckily, she doesn't use any drug. And then how's her drinking? She only have some beers during weekends, so we can already exclude some overdose. Overdose also includes alcoholic or other stuff. And then we can exclude. We can't exclude PE during this moment because we haven't done our examinations. Even though she says she don't have any difficulties in breathing, but still we have to. There's a protocol we have to go through to exclude this disease. So that's what I'm going to talk about in the next step. So you, after a brief question, you're going to check on her, and then the most two important examination is the circulation exam and the cardiovascular exams. You have to exclude those big boys, those heart disease. So the results came. We know that it's normal. We have 2+. Means like normal peripheral pulses, normal capillary fill, regular rate rhythm, blah blah blah. Nothing wrong, nothing unusual. And then this is recommended. Like it's not the critical, but still, you better do it. Still, like don't miss it. So we're gonna continue for the pulmonary exam. You can hear it's very normal, but still in this part, even though you hear nothing abnormal, unusual, still you cannot exclude the pulmonary embolism. That's why you have to memorize the PELC rule. This is because this patient is a no risk patient. She's young, and then she doesn't show any symptoms, any signs. Like the signs I said is like when you check on the MSK, the musculoskeletal examination, you didn't see anything unusual, or you look at her skin, you didn't see any unusual bruise, or so at this moment you still can't exclude the PE. So according to this rule, she's not over 50 years old, so we can rule it out. Nope. Her heart rate, I haven't given it out yet, but it's in the next page. Heart rate. Her heart rate. Where is it? Oh. Anyway, the slide is gone, but anyway, so her the information I have in my hand is her heart rate is normal, so we can cross it out. Also, her oxygen O2 stat is normal. We can cross it out. During the examination observation, we haven't seen anything here, and she doesn't use any estrogen. If she's history is just stated in the previous session, which during our history taking, and then she has no periodicity of PE, which we can see it in the computer of her history, or we just ask her like any medical history, she just denied it, so we can say it's no. And then uterine leg swelling, nope. During our check, we didn't see anything like this. And then is any surgery or trauma within last 4 weeks? Nope, in this case. Then we can fully exclude there's no PE in this patient. What a relief. What a relief. Then we can move on. Okay, then we can move on to figure out what tests we have to order. FBC, the normal basic stuff, and you can exclude anemia or sign of infections. Then we know it's not because of anemia causing her faint. And then we order the CAM7, the basic stuff, and then we can check. Also, usually the CAM7 doesn't include magnesium, right? But still, you have to order magnesium because one of the causes of fainting is hypomagnesemia, so you have to order it. Then we have the result here. I just include those which appears abnormal, which is the potassium and magnesium. They both have hypokalemia and hypomagnesemia. Then we have to take care about it later, and then we have to check the ECG because, like, if you face a woman that is a young woman that's faint for no reason, you still have to order this to exclude what if she's pregnant or not. This is just protocol. And then, of course, you have to order ECG. This is the most important thing for your diagnosis, especially in young patients. You have to take extra focus, extra time to look through it. Then you order a chest X-ray. So still is one of the, you can exclude PE or cardiomyopathy. And it's recommended. It depends if your hospital policy doesn't like you to order it because it's time consuming or expensive, whatever. It depends on the hospital or your style or your boss, your department style. Then you can also perform a bedside echo to see if there's anything structural problems, such as we can exclude the arteriosclerosis that I mentioned before. In this case, there's nothing unusual in this patient. So the only clue we have left is the ECG. So we look at the lead one here. Nothing wrong. Normal. It's sinus tachycardia. By the way, you can just look at here. Quite obvious. Then normal. Here, that's what things go interesting because here there's an ST elevation. So when you're new or you're a student, just learn how to read an ECG. When you see ST elevation, you think, oh, this must be a heart disease. It must have a coronary artery, disease. And then I was like, no, wait, hold on. ST elevation can represent many stuff in this case. And then we can continue to read through it, and then we can still see a acceleration here. And then apart from acceleration, we can also see it here. There's a T wave, reverse T wave, and then V3 here, slightly also acceleration, and then there's a reverse T wave inversions. Maybe we should just focus on the V2 and V1 because V3 is not very obvious. So it's the V2, V1 and V2. We can see there's ST elevations and T wave inversions. So you must have something comes into your mind. So a young patient suddenly faints, syncope, and then there's no previous disease and nothing unusual, not taking any drugs, neither illegal drugs or others may trigger the situation, not having structural heart disease. So the only thing you can think of is Brugada syndrome. And then I'm going to talk about this in details later, but let's talk about how to manage this patient. So you have Brugada syndrome in your mind, right? So, but still, don't forget about these two. You have to fix it. So what you're going to do before the hands off, you have to give potassium chloride and magnesium sulfate burst for this patient, and then you have to consult cardiology because you're just you have to ask them. I think I don't have to explain about this one. Then they just say they'll take care of it, and then you hands off the patient to them, and then you send the patient to telemetry unit. Because like if you don't treat it properly, they probably just have arrhythmia, and then just the things go into really critical, and then you don't want to miss the treatment. So send her in to the telemetry unit, and then I'm gonna talk about the treatment in details in the next few slides. So usually it must be a type 1. This is a type 1 Brugada syndrome. A type 1 Brugada syndrome, this is the only diagnostic type. Then just like we talked about in the previous ECG slides, we can diagnose it from the V1 and V2, which represent the right heart structure. Why are we looking at V1, V2? Because according to research, there are two possible mechanisms behind it. Like one of it, they most focus on explaining on the right ventricular conduction anomalies. One of the theory is because one of there's a mutation of the gene SCN5A. This is the gene of the cardiac sodium gate channel. So the cardiac sodium gate channel lost function, and then it produces a notch like this in the action potential of the right ventricular epithelium. So So it creates differences in action potential in between epicardium. Like imagine this is your heart muscle. This is a cross section, and here, there's a typo. It should be endocardium. My bad. Sorry. So there will be a created difference in right ventricular epicardium and endocardium, like this. Use your imagination. I try my best to draw it. Thank you very much. Then, so these differences create arrhythmia, and also another theory is there will be a delayed depolarization by slow conduction in right ventricular outflow tract, and also promote arrhythmia. So that's why we have to focus on the V1 and V2 and even V3, because if you know about the ECG, those V1, 2, 3, 4, 5, 6. It might not be accurate, but I try my best. And then I try. And then so here is the right heart structure. So you have to focus on the 1, 2, 3 lead, V1, 2, 3 lead. And then they usually focus with T wave inversion. So what you have to remember for type 1 is larger than 2 millimeters, like 2 small boxes. Obviously it's more than 2 boxes here. Then you pass this criteria, and also T wave inversion, you pass the criteria. And nowadays there's some studies say you can't use ECG only to diagnose this syndrome, so you have to combine with the clinical criteria. In this case, we are patient Syncope, so we can diagnose she got Brugada syndrome in this case. In other criteria, you can see here, is there any family history of cardiac death under 45 years old, and then do they have a curve type ECG in their family members, if they have programmed electrical stimulation able to trigger a ventricular tachycardia, and then is there any agonal respiration at night. So you have to observe and combine with the ECG finding to make a diagnosis of this syndrome, type 1. And there's because we mentioned type 1, there must be other type, right? So we also have type 2 and type 3. But remember, they are not diagnostic. But if you also find this in your patient, you have to order other tests. Like, you have to make sure they don't have they don't have arrhythmia or other thing else. Like this type 2 and 3 is only a sign for you to examine this patient, try to figure out what other stuff hidden. So you have to just find out, but I'm not going to talk about it in this in this video. So the type 2, as here is very clear. You have a saddleback type. Saddleback type is what you call this shape of ST elevations. And then type 3 is similar to type 1. The only difference is smaller than 2 millimeters. ST elevation here is only one box in this case. So unlike in here, there's 2 boxes, is larger than 2 millimeters. So this is how you differentiate type 1 and type 3 and also type 2. So while you're treating or take care of this patient, you have to be aware of, like, you might think there's arrhythmia because it's gonna cause arrhythmia, right? But you're not remember not to use class 1A and 1C drugs because they're gonna unmask the syndrome and then induce arrhythmia. Because like these 2 drugs, they're gonna block the normal, even they block the sodium channel, right? So they even block those normal functioning sodium channel. So there's nothing else like working functioning channels left, cardiac voltage case sodium channel left. So your heart is gonna experience arrhythmia. So you're not gonna remember not to use class 1A and 1C antiarrhythmic drugs. And also the study already found out the beta blockers and amiodarone, they're not effective, so it's useless to use them. And then you have to remind the patient to avoid use large meals, excessive alcohol or cocaine. But about the treatment, so what can you do for the treatment? If there's acute, the patient experiencing arrhythmia, such as like polymorphic ventricular tachycardia, or it's gonna have a refib. So you're gonna just rush him to the ICU and sedate the patient, even in case. So it's this one is up to the supervisors, the consultants. They decide to give the patient general anesthesia, and even though intubation if this needed. So what you can do, you can focus on eliminate the potential triggers of the electrical storm, such as like a serious hypokalemia or other stuff. You can't, like, that's gonna happen at the same time, so it depends on the situations. But usually the only definitive treatment is an ICD, an implantable cardiac defibrillator. So there's only this method can treat the patient. There's nothing else. But if the patient is too little, just as a neonate, a baby, or the patient refuses to implant this device, it's understandable. So what you can only do is give quinidine to this patient. And what else? If the patient, they have ICD already, but they're still experiencing an electrical storm, the ICD already give them shocks, multiple shocks, but still cannot correct the situation, then you have to give them quinidine. And I think this is the end of my share. Welcome, please. This is my first video, so I might not doing this very well, but thank you for listening. Feel free to correct me in the comment section or share your experience in the comment section, and I'm willing to for your feedbacks. Thank you very much, and bye. This video is sponsored by General Engineering. Thank you so much for giving this opportunity.